Good evening, ladies and gentlemen. Welcome to another trial class with me. For those of you who are having the trial class for the first aid AMC regarding the recall session, my name is Rabia Farid. I'm one of the doctors associated with the first AMC course. I welcome all of you to today's last trial class of the first 2 weeks of the trial class associated with the first aid AMC MCQ course. We'll just wait 5 more minutes so that maximum number of participants can join, and then we'll start our class. Good evening, Dr. Kanpil. How are you? So regarding first aid AMC MCQ course, it's a 5 months online course. We have been doing trial classes for 2 weeks with one of the tutors, Dr. Arshan, who is the main course coordinator. And there are 3 tutors associated other than him with this course. So what we usually do is collect as many recalls as possible for the months that we are teaching you, and we try to discuss the recall in a very interactive session as an online class for 2 hours. And in these recall session, we discuss with you the tips and tricks about how to solve the questions during your exam, also about which topics you need to focus more on, and how to get your grip about what they usually do in an Australian health system. Good evening, Dr. Hassanul and Dr. Zahid. How are you guys? So we go in very much detail about how to go about preparing yourself for the exam. It's a very doable exam with the right guidance and the right sources available. The first aid AMC MCQ course equips you with the sources. It basically provides all the material to you guys so that you can cram it up and make a very good base for your exam. And also when you're going to be entering an Australian health system, you need to have a very good base and you need to be practicing in a very safe manner. So we help you guys achieve those goals. Good evening, Dr. Adil and Dr. Sumit. How are you guys? Welcome to the class. Good evening, Dr. Charles. All right. Let's just wait a few more minutes so that maximum number of people can join. And then we'll start the class. I'll discuss about the resources that we usually use in solving the recalls that can help you guys in future. Also, the resources that we use are not only used for just studying, they are the guidelines that are implemented every year in the practicing of the medicine in Australian health system. So you're not just preparing for an exam with us, you are basically preparing yourself as a doctor to enter the Australian health system, and you will be equipped with the knowledge about their system and their guidelines so that you can perform very better and in a very safe manner. Because what usually the Australian health system is all about the safety of the patients and the safety of the doctors. So try to approach everything in a very safe manner in regards to your patient, even in the theoretical exam. Good evening, Dr. Nandini. How are you? All right, I'll be sharing the screen with you guys. Just give me a minute. All right. Are you guys able to see the screen? Just write Y in the chat box so that I'm better able to communicate with you guys. All right. Thank you so much, Dr. Aisha. Thank you so much, Dr. Sana. And oh my, it's coming up really quick. Thank you all of you for telling me. All righty. So let's discuss about the resources first. I'm just going to put a blank space first. If you have any troubles with my voice, please let me know, because sometimes I have sometimes trouble with the speakers. So do let me know if my voice is not clear so that I'll adjust it on my end. So the main resource or the main book for your exam for AMC MCQ is John Murtagh. And the latest edition, I believe it's the 8th or 9th edition now, which is the latest one. So this is your core book from which you'll be studying most of the topics. And it has basically all the material you require for your exam. Now, sometimes the books are not as updated as we like them to be, but there are other things which are more updated, and those are the guidelines. So for the GP practices, we use the RACGP guidelines. And in the hospital settings, you can use the guidelines of each and every one of the states. So there's Queensland Health Guidelines, New South Wales, Victorian Health Guidelines, South Australian guidelines. So I usually prefer the Queensland guidelines. New South Wales has excellent guidelines for emergency medicine. South Australian have excellent guidelines for the obs and gynae. Victorian have good guidelines for the surgery. So for specific things, I do sometimes talk to my students and tell them about like South Australian guidelines. I always use them whenever I'm teaching about the obstetrics and gynecology. They're excellent. They have very good algorithms. So even if you just go through those, it's more than enough for your exam. You basically know what you're supposed to be doing. Now, sometimes we use some other resources as well, like Kaplan. We use Kaplan for surgery and MedBullets for hematology, because MedBullets have questions for hematology that can give you an idea about how the questions related to the blood diseases come in the exam. Also OrthoBullets for orthopedics. You can simply type what topic you're studying and just write, for example, postpartum hemorrhage essay health guideline, and it will come up with the guideline itself. And OrthoBullets for the orthopedics. OrthoBullets is very nice in a sense that it has all the x-rays available that can come into your exam. So it's more feasible for that manner. Alrighty, just gonna close this. So let's start our class. No, they don't differ. They don't differ. Basically, the initial management is same. Initial investigations are same across all the states. There is no difference. And you don't need to specifically study from one state. They apply, for example, I live in Queensland, but most of the time we are following the latest guidelines for the emergency from the New South Wales as well as the Queensland ones. And for obstetrics and gynecology, we also follow some of the Queensland guidelines and some of the SA Health guidelines. So it's a spread across. Ma'am, notes are enough for exam because studying whole book is a bit difficult. It is a bit difficult, but if you go through it, not just in so much detail, with this course, we will help you go through the theoretical part in 5 months. That will be enough for you guys. 5 months is enough to go through everything once. And you book your exam like 1 month or 2 months later, they are enough to revise everything as well. All right, so let's start our class today. I'll let you guys know about whatever I'm underlining. These are the most important clues to look for in a question. So, 32-year-old woman came with green vaginal discharge. She had an implant on 3 years ago. She lives with her female sexual partner. Diagnosis of the bacterial vaginosis was made and she was given metronidazole. What else would you want to do in this person? Treat her partner, remove the implanon, test for the STI. Nothing further is required. Now, there are two clues over here. Number one is that she is having bacteriovaginosis. We have the diagnosis for it. Bacteriovaginosis, is it a sexually transmitted infection? Can anyone tell me? No, but one of the main concerns here is that she has a female partner. So bacteriovaginosis can, yes, very important. She has a female partner. So bacteriovaginosis can spread if the partners are both female, then it can sort of become like a sexually transmitted infection. So very important thing is to treat the partner as well. And then the next step we'll do is test for the sexually transmitted infection. So correct option here is option A. As the patient is a female who is having a female sexual partner with bacterial vaginosis, if both partners are female and one of them are diagnosed with bacterial vaginosis, it is recommended that you treat both of them and then test both of them for the sexually transmitted infections. So we'll treat both of them and then we'll test them for the sexually transmitted infections. Removing the implanon. Implanon is not removed only if you're diagnosed with the very initial stages of the STI or STI-like illness. It is removed after the treatment of it. Otherwise, there is a chance you're going to perforate things along the way or spread the infection. Test for the STI is a good option to select, but firstly, we'll treat both of them and then test both of them for the STI. Nothing further required is not a good option because they have clearly mentioned that it's a female and partner is female and she is having bacteriovaginosis. Now, let me share the screen with you guys. This is the Australian Sexually Transmitted Infection Management Guidelines. So if you write in the, if the partner is male, we don't need to treat. We don't need to treat both of them. But if the partner is female and both of them, like every person in the relationship is a female, we need to treat both of them. All right. Now, for your exam, every population disease or sexually transmitted infection, you need to study from here. STI guideline, Australia. Just write in Google STI guidelines, Australia, this will come up. Okay. So every STI, look over here, chlamydia, donovenosis, ectoparasite, all of them will come over here. So bacteriovaginosis, most common cause of abdominal vaginal discharge in women of childbearing age. Sorry, I'm just adjusting it to my screen. It's caused by Gardnerella vaginalis, Etobium vaginae, Mobilensis, and Provitella. You need to know about these names because they're asked about it. There are associated bacteria present in the urethra and penile skin in partners of people with bacterial vaginosis, and women who have sexual intercourse with women show very high incidence of bacterial vaginosis within partnerships. Post-treatment recurrence of bacterial vaginosis is associated with the exposure to an ongoing sex partner and lack of use of the barrier methods. So clinical presentation is the same as that of a UTI, like STI, malodorous vaginal discharge. It will be thin white or grayish in color, asymptomatic sometimes, increased risk of abortion, premature labor, chorioamnionitis, endometritis, PID, and also puts you at risk for other sexually transmitted infection. Diagnosis. How do we make a diagnosis? We do a speculum examination. We can check the vaginal pH, which will be alkalosis. We do a whiff test. And whenever we take a swab for culture and microscopy, it shows clue cells. Self-collection can be done, or you can do it while you're doing the speculum examination. Treatment is metronidazole for 7 days, 400 milligrams twice daily. Or if a patient who can't have it, you can give clindamycin as well. Or you can give metronidazole as a gel, or you can give clindamycin as a gel as well. Evidence does not support routine screening for bacterial vaginosis in low-risk pregnancy before surgical termination of pregnancy or insertion of IUD in asymptomatic patient. Bacterial vaginosis diagnosis or suspected at the time of IUD insertion should be treated with no need to delay the procedure, and it doesn't require any coverage antibiotics as well. Copper IUDs have increased risk of bacterial vaginosis. So if a person is using an IUD develops, you treat as recommended. And if the patient is having recurrent, then you need to remove it and use an alternative treatment. This is very important, okay? So first episode, you don't need to remove the IUD, but if having recurrent, which means that patient is having at least 3 or more episodes within 12 months, then you need to treat it and remove the IUD after the treatment as well. So special situations, they have already given. Contact tracing is also required. Follow-up is not necessary in these patients. Is it clear, guys? Isn't Implanon expired? It might be expired. 3 years. If 3 years, then yeah, he might have Implanon removed afterwards. But if having recurrent and still having an IUD, which might be a cause of it, then you treat the bacterial vaginosis and then remove the IUD. Not during the acute infection. Never do that. It will cause a dissemination and turn it into endometriosis, endometritis and PID. Achilles fracture on X-ray is given. How will you apply the cast on the patient? I will show you guys the X-ray. Flexion and below the elbow, flexion of the wrist and above the elbow, extension of the wrist and below the elbow, extension of the wrist and above the elbow, flexion of the wrist with ulnar deviation and pronation. And this is your X-ray. So can anyone tell me what are the findings in the Achilles fracture X-ray? Very good. Your answer is absolutely correct. What are the findings in the Achilles fracture? Distal end of the radius is fractured and it is posteriorly displaced with angulation, okay? It's not just the distal end of the radius fracture. If the distal end of the radius is fractured and anteriorly displaced, what would you call it then? That is a different fracture. Yes, it's a Smith's fracture. So you need to remember anterior angulation and posterior angulation, and this will differ the type of fracture your patient is having. So very good. Whenever we have a Achilles fracture, we flex, ulnar deviated and pronation of the hand, and then we apply the cast in that way. So look at this one. I'm just gonna look at this. It's just like you're about to shake somebody's hand. Flexion at the wrist, ulnar deviation, and a bit pronated. This is the way. And it's always below the elbow. You guys can look about the Achilles fracture from this, but I'm not going to go in that much detail. All right, next question. Sorry. About what do you need to know about, Dr. Zina? About the cast application. Achilles fracture is a fracture of the distal end of the radius in which the distal end of the fractured radius is displaced in a dorsal angulation. Whereas Smith fracture is a type of fracture in which there is anterior angulation of the distal end of the radius, which is fractured. And then we apply the cast and Cooley's in ulnar deviation, meaning the hand is deviated in towards the ulna, and it is a bit flexed, and the whole arm is forearm is in pronated position. Now, a patient took rubella vaccination 2 weeks ago. And 2 weeks ago, so 1 week before her periods, she missed her periods and she confirmed that she is pregnant. What will you do next? Advise her not to worry? Sorry, I'm just going to mute. If you guys have any questions, you please ask in the chat box. We try not to do the conversations because it takes a lot of time. So just try to write in your chat box about the queries and all will be good. Sorry, where were we? Advise her not to worry. Do a rubella serology, termination of the pregnancy, or follow-up. So now, what will be your best advice to this patient? All right, so follow-up is not a good advice. Follow-up for what? What do you want to follow up for? You haven't done anything. What do you want to follow up this patient? Very, very vague answer. We never advise termination of the pregnancy unless we are very sure the patient has contracted rubella and it's in the first trimester and it has been transmitted to the baby as well, right? Advise her not to worry is not a good option as well. We need to investigate it, so we will do the rubella serology. Excellent. So rubella serology is the safest answer here because she had the vaccination and now she's pregnant. So rubella serology will tell us whether she is having any antibodies formation in the body or not. All right, so sometimes I will use the NCBI, which is basically the evidence-related studies. Sometimes I can't find good answers in the guidelines, so I use evidence-based investigations. So if you look over here, German measles is rubella. It can be very serious for the baby. It can lead to congenital defects like blindness and deafness in the baby, and can cause termination, miscarriage as well in the baby. So when is someone infectious? When they are coming in contact with the rubella and have contracted the virus in their system. A baby born damaged by rubella is having a congenital rubella syndrome, and they have eye defects, ear defects, heart problems, and these baby does not survive much, and they usually are miscarried. But if they're still viable, we usually advise termination of the pregnancies, but the decision is made by the parents. Rubella caught in the first 10 weeks of pregnancy causes damage to 9 out of 10 unborn babies. So the incidence of the congenital rubella syndrome in a patient is very high. Vaccination is the best protection against rubella. If you haven't been vaccinated or unsure if you have been, there's a number of things you can do to ensure your family is safe. How do I know if I'm protected against rubella? You need to be sure you had rubella in the past, or you had 2 or more immunizations of the MMR as a child. If you're not sure, check with your doctor. You may need to have a blood test to check the immunity, just like we are doing in our female. Some young women who may not be think about planning a pregnancy missed out their immunization when they were a child. They are particularly at risk. So if they don't remember, sometimes they ask in the exam as well, that the person doesn't remember if she has been vaccinated against rubella or if she had rubella in the past. The best thing is that if she is planning for pregnancy, vaccinate her and ask her not to start planning the pregnancy at least 3 months later. Two MMR immunizations 3 months apart, and with the second one at least a month before pregnancy will offer excellent protection against the disease. What else? I'm pregnant and my blood test shows I'm not immune to rubella. What can I do? Success of the MMR vaccination program has meant that there's very little rubella circulating in the population. Even if you're not vaccinated and you're pregnant, the best thing you can do is try to protect yourself from the person who might have any flu-like symptoms. Can I have MMR immunizations when I'm pregnant? That is not recommended. There's no evidence that the vaccine causes harm to unborn babies, but if you need the vaccine, you should have it after your baby is born. Usually in pregnant females, we don't do any studies because there is always a unknown risk to the babies. I have only recently had my MMR vaccination. Sorry about that. So this is our question. I have only recently had my MMR immunizations and now I'm pregnant. Will my baby be okay? It's best to have your immunization at least a month before you're pregnant. There is no evidence that vaccine caused rubella damage, but if you are worried, talk to your GP. And what can you do? You can do a test. You can do a serology test. All right. I'm pregnant and my friend has rubella. What should I do? Try to contact your doctor. If you have immunization in the past and you come in contact with someone who is rubella positive, they will do a serology test. I'm pregnant and I'm having a rash. What should I do? It may not be rubella, but talk to your doctor. You may need to have a rubella blood test done just to check the cause of the rash. All right. Is it clear, guys? All righty. Next question. Sorry about the disturbance. I have a little bub. So if you are going to be enrolling in the first aid AMC course, you might be hearing some noises in the background, and I apologize in advance about that. All righty. A patient came to you and he has or she has a 1 centimeter stone at the that is the wrong spelling, uretropelvic junction. What to do next? Do extracorporeal shock wave lithotripsy, do a percutaneous nephrolithotomy, do a uteroscopy and removal. So it's a 1 centimeter stone and it's at the ureter and pelvic junction. Very good. So there are different guidelines that help you about the stone in the kidney. Urology guidelines are also very well, but in your exam, they don't ask in very much detailed questions about that. Otherwise, it will become a very specialist exam. They ask questions at the level of the junior doctor. So whenever you have a stone of less than 1 centimeter, equal to 1 centimeter in the renal pelvis, calyces, or in the uretropelvic junction, we can do a external shock wave lithotripsy. If it is more than 1 centimeter, what will you do then? if it is more than 1 centimeter, very good. 1 centimeter stone, more than 1 centimeter stone, you cannot, usually they are not broken down with the lithotripsy. So you have to remove it by the percutaneous nephrolithotomy. And if there are stones anywhere in the ureter, then you can either use the external shockwave lithotripsy, or you can remove it with the ureteroscopic Dormia basket removal. I'll show you guys about the RSCGP. They have very good discussion regarding this topic. So they're talking about the urolithiasis and 10 things every general practitioner must know about. Are you guys able to see this? Oh, okay. What test should I order when a person is coming to you with the renal colic? For example, a person comes to you complaining of a unilateral pain going from loin to groin, very bad pain. And usually it comes and goes and it's associated with nausea and vomiting, and patient might also complain of hematuria. So the first thing is you do is the urine dipstick or urine microscopy and culture. And then you do a CT-KUB. That is the first thing we do. We don't do X-rays as a first imaging. We use CT-KUB as a first imaging, and it will tell us about the radio-opaque or radio-dense stones. Ultrasonography can be used in patients instead of CT, but which patients we use ultrasonography for the urolithiasis? For very young patients, like pediatric age group, and women who are pregnant. We usually don't expose them to CT because it's of high radiation. So it is a clinician-made decision. Now, CT-KUB is a test that is performed to tell you about the type of stones. And CT-IVP is a contrast scan that you do. And it gives you information about whether there is urodynamic problems in the bladder, kidney, or ureter. And it's also CT-IVP, it's more useful for diagnosis masses of the renal parts. For example, cancer, CT-KUB will not give you more information about the anatomical relation of it. Instead, we do CT-IVP for that. But for renal colic, CT-KUB is the best thing that we do. Red flags for renal colic is that you're having an infection. If a patient is having an infection with the renal stone, if a patient is having recurrent renal stone, or if a patient becomes oliguric with the renal stone, these are the red flags to do surgical management. Now, which stones should pass and you should not be concerned about? If the stones are 5 to 7 millimeter, they will usually pass. But if it is more than 10 millimeter, the chances of them passing are very low. So for these patients, we usually give them NSAIDs that helps them that helps the ureter to expel them. So with these stones, don't be worried about that much. It can pass on its own. And we usually ask the patients to pee in a jar for the next 3 days so that they can tell us if they have passed it or not. But more than 10, you need intervention for that. So what kind of NSAIDs you can use? You can use it orally, rectally, intramuscular, IV use. For example, acute pain, the patient is coming in the emergency. Don't give oral NSAIDs, give IV ibuprofen for this patient. And sometimes Temilocin as well. It can help the patient to pass the stones. Who needs a referral to the urologist? Stones bigger than 10 millimeter. So laser lithotripsy is usually done for the stones which are very difficult to remove by itself. Less than 20 millimeter inside, most stones respond to that. What stones can be broken down from extracorporeal shockwave lithotripsy? 5 to 10 millimeter stone in renal calyces and renal pelvis. They can be easily broken down by it. For percutaneous, that is a stone which is more than 2 centimeter. That requires percutaneous nephrolithotomy. What else? For recurrent stone, we usually advise them about dietary onset. That will be it. Any question, guys? So if you look over here, more than 10 millimeter, sorry, less than 10 millimeter, you can use shockwave lithotripsy or ureteroscopy for the removal. Pain tolerable, no fevers, able to take in adequate paroral, then you just do medical expulsive therapy like with NSAIDs. If the patient develops, no, X-ray KUB and CT KUB are not the same. We never do X-ray KUB here for the management of the stones. We never do it. CT KUB is the first thing that you do. X-ray KUB can be done as a follow-up by the GP after the first CT KUB is done. X-ray KUB can be done afterwards to see whether you have passed the stone or not, if it is a radiopaque one. All right, so if you develop a fever, then you need to put an emergency stent in the patient or nephrostomy should be done. If it's in a ureter and more than 10 millimeter, in the distal ureter, you can use shockwave lithotripsy or ureteroscopy. If it's in the proximal one, you can use shockwave lithotripsy, but if it is more than 2 millimeter, percutaneous nephrolithotomy can be done. Rarely it leads to very big surgical operations. So less than 10, shockwave lithotripsy, renal stone, all but lower pole, 10 to 20 millimeter. Need to know about the location, okay? So more than 20, percutaneous nephrolithotomy, 10 to 20, shockwave lithotripsy, less than 10, shockwave lithotripsy. Lower pole stone, 10 to 20. Unfavorable to shockwave lithotripsy, you need to do endourology, which is the ureteroscopy. Then you can move. Ureteroscopy sometimes is accompanied by shockwave lithotripsy. So stones which can't be removed in the ureter by the ureteroscopy, we have a very small lithotripsy device which can just shoot some lithotripsy waves on it and cause it to break down, and then you can extract it with the Dormia basket. All right, next question. 64-year-old patient presented to emergency department with leg pain. ABI, which is the ankle brachial index, is 0.2. Patient smokes 40 cigarettes a day. What to do best next? Cease smoking, ACE inhibitors, statins, compression stockings, or CT arteriogram. Okay, so we are between A and E. Most of the people are answering E. Can any one of you justify your answer? Your answer is absolutely correct. But can any one of you justify your answer? Why we are doing CT arteriogram or angiography? Very good. Ankle brachial index is 0.2. It's like severe peripheral artery disease. Critical limb ischemia. Very good. Excellent. Need urgent intervention. So whenever there is an ankle brachial index of 0.2, we need to refer the patient to the vascular surgeon. And the vascular surgeon, if you're in a secondary center and you have the facility to do a CT arteriography or angiography, do that before sending the patient to the vascular surgeon, because they need to plan a surgical intervention. If you have the facility to do this, then it will become very easy for them to intervene on your behalf. They will tell you what to do before the patient is transferred, because it takes time for the patient to be transferred, right? So they will tell you about what we can do to minimize the damage to the limb while transporting the patient. Excellent. I do agree with you guys. Cessation of the smoking adding ACE inhibitors, adding statins are all very good options, but they are not the best options in a patient who is having ABI of 0.2 and having critical limb ischemia. Cessation of smoking, ACE inhibitors, statins, they're not going to do anything to prevent the critical limb ischemia. CT arteriogram is going to help visualize the clot or the atherosclerotic plaque, and it will help us to plan a surgical intervention. Excellent. Yes, there is a critical range. Less than 0.4 is critical. 0.9 to 1 is normal. 0.9 to 0.4 is mild, moderate. And then less than 0.4 is severe or critical limb ischemia. I'll show you guys. Just give me a second. I think I have opened it up somewhere over here. Oh, yeah. Look at this. Lower extremity peripheral artery disease diagnosis and treatment. So what do you need to do? So patient at increased risk of the peripheral artery disease should be assessed for the exertional leg symptoms, ischemic rest pain, non-healing wounds, vascular examination should be done, auscultation should be done, resting ABI and exercise ABI should be performed, and a range should be made for it. ABI screening should not be performed in asymptomatic patients who are not at risk of the PAD. Otherwise, it will give you false positive results. Primary strategies is lifestyle modification for non-critical limb ischemias, angiotensin ACE inhibitors, statin, and antiplatelet therapy. I agree with all of you. These are the things you need to do in patients who are having non-critical limb ischemia. But interventions, including surgical bypass, angiogram, angioplasty, or stent should not be a first line for most of the patient with intermittent claudication. Intermittent claudication happens in chronic limb ischemia, not for acute limb ischemia, okay? Risk factors, renal dysfunction, heart failure, age more than 65, hypercholesteremia, MI changes, ankle brachial index less than 0.6, Q waves on ECG, which usually suggest old MI, cerebral vascular disease, diabetes, pulmonary disease, statin use, aspirin use, beta blockers. So these are all risk factors. Where patient increased risk, all of the above with having the risk factors. I'm just gonna go towards the diminished lower extremity pulses, impaired walking function, intermittent claudication, ischemic rest pain, lower extremity gangrene, non-healing lower extremity wound, failure on elevation of the legs, and dependent rubor or vascular bruit. These are the physical findings of it. This is the rubor test. Diagnostic testing, ABI is the first thing. So this is the ankle brachial index. 1 to 1.3 normal, 0.9 to 1 borderline, 0.7 to 0.9 mild, 0.4 to 0.7 moderate, less than 0.4 very severe. Critical acute limb ischemia, which our patient was having. Limb-threatening or critical limb ischemia is manifested by chronic ischemia rest pain for more than 2 weeks, which is not intermittent anymore. It is constant pain, all right? Ischemic rest pain occurs soon after falling asleep, and patient is awakened by burning pain and numbness in the foot. Symptoms are often relieved when a patient is hanging the limb on the side of the bed, triggering the dependent rubor of the foot. Urgent referral to the vascular surgeon is required. It's a medical emergency, describes the abrupt interruption of the blood flow to the limb, and patient presents to you with 6 Ps. Oh. Sorry, I'm going to mute all of you. What are the 6 Ps? There will be pain, pale extremity, absent or diminished pulses, motor changes. Sorry about that. Sensory impairment or paresthesias. Whereas in critical limb ischemia, there is a gradual worsening. And you would have a window of only 4 to 6 hours.
இது டை அடிக்கிறதுக்கு பதிலா நேச்சுரலா வர இந்த
Can all of you mute yourself? I'm unable to, because I'm hearing some voice in my ear, which I'm unable to mute. Okay, that's good. So you have only a window of 4 to 6 hours. As soon as acute critical limb ischemia happens, you just have a window of 4 to 6 hours. So evaluation is done with the vascular surgeon. So it's relative to the coronary artery disease. You can do the exercise, do the drug therapy with the antiplatelet, anticoagulation, statin, antihypertensive, medications to improve circulatory flow. But for the critical limb ischemia, we do the surgery, and for the surgery, we do the CT angiography or arteriogram, which will tell us about where the blockage is, and then you refer the patient to the vascular surgeons, okay? Is it clear, guys? This is how CT arteriogram look like. Is it clear what is going on? Can you please go? Sorry, guys, I have to discuss a lot of patients. We will discuss the whole theory in the theoretical classes. In the recall classes, I'll just tell you guys how to solve the question and the reference for the correct answer. That's it. Whereas you're having confusion, I'll help you guys with that, but I'll not go very deep into the topic. I'm sorry about that, but I'll just tell you how to check the resources, how to solve it, how to use the methods and tips and tricks to solve the question. No, this 5-month course is not recall based. You will be having theoretical class every week, and then you will be having, I think, 3 classes every week with the recalls as well. So 3 theory classes and 3 recall classes. We go side by side. No worries. All right, next question. A patient presented to emergency department after head trauma, and he is having rhinorrhea, which is basically the CSF is leaking from the nose. And you know it's a cerebrospinal fluid. The patient also has a periorbital hematoma. What do you want to do next? Insert a oral gastric tube, do a primary survey, order a CT scan, lean forward, pinch the patient's nose, observe and give pain relief. 2 theory classes and at least 2 or 3 recall classes per week. Alrighty, so we got maximum number of people who are answering it as B. We never observe and give pain relief in a patient who is having CSF leakage from the nose and having signs of what are the signs of head trauma with not orbital floor fracture. Good, you're almost there. It's the base of the skull fracture. Base skull fracture present with the leakage of the CSF from the nose and ears, periorbital hematoma, and battle sign, which is bruising on the mastoid. If you see this sign on a patient, it's a patient who is having basal skull fracture. But before ordering the CT scan, we need to make sure that the patient's airway, breathing, and circulation is okay. Because if this is a head trauma patient and you are sending him straight to the CT scan room without making sure airway, breathing, circulation is okay, patient might collapse and die during the CT scan. So make sure that you do a primary survey, optimize him enough to be sent to the CT scan, okay? So primary survey is very important in a trauma patient, very, very important. Head injury guideline. Okay, so this is the Head injury guideline. I'm just going to show you guys the algorithm of it. Okay. A patient presents to you with a head injury. You need clinical assessment of the child within or adults. It applies to both of them. You do a GCS check and do a primary survey as well. So if GCS is less than 13, alert the senior clinician and do a head CT immediately. Primary survey means you assess the patient for airway, breathing, circulation, disability, and exposure. These are the initial management of every patient who comes in the emergency department following a trauma or whatever. We need to make sure airway, breathing, circulation is intact before we send the patient off for any imaging. All right. So whenever we see a patient, we need to categorize them whether they're high risk, intermediate risk, or low risk. How do we do that? We do that by assessing airway, breathing, circulation, disability, and exposure. We check the GCS, all right? And we classify the patient according to that. High risk patient, alert the senior clinician, stabilize the patient, send to the CT, and consult the neurosurgical department and do the management from there onward. Intermediate risk patient, we can optimize the patient first, send for a CT scan, and then evaluate. Low risk, GCS is being maintained. There is no sign of the base of skull fracture. You can delay the CT scan in these patients, but you need to observe these patients in the emergency department for at least for at least 6 or 4 hours. Just going to go through quickly. Head trauma. These are the full guidelines. So if you need to study the emergency guidelines, you can go through this one. It has everything you need to know about any emergency medicine guidelines. If base skull fracture patient stable saturation 90, should we do intubation straight away or oropharyngeal tube? If the patient is able to tolerate and is desaturating and you know there is a base of the skull fracture, don't delay the intubation. We never delay the intubation. So go ahead straight away with the intubation. Saturation 90 is meaning the patient is desaturating. His normal saturation is more than 95% on room air. If patient is not maintaining that, intubate the patient. All right, next question. A patient 75 years old, male, has an aortic aneurysm, abdominal one, and is on surveillance. But the size of it is increased from 3.2 to 3.8 centimeter in 2 years. Now, how will you do the further surveillance of the patient? Yearly? Twice in a year? 6 monthly? Oh, sorry, biennial means 24? Or do nothing? Yearly means 12 monthly, biennial means 24 monthly, 6 monthly, or none. Okay, I'm having a lot of different answers. So according to the guidelines, we need to, if the patient is having 3.8, then we need to do 24 or 2 yearly follow-up. All right, look at this. Oh, not this one, sorry. Look at this. It's still there within the 24-month range. So if the abdominal aortic diameter is from 3 to 3.9 centimeter, you're still doing 24 monthly surveillance. If it is from 4 to 4.5, then you're moving on to the yearly. If it is 4.6 to 5, you're moving on to 6 monthly. If it is more than 5, 3 monthly, you need to do. But if it is more than 5 in males, you need to do intervention. If it is more than 5 in females, you continue to do surveillance. Clear, guys? So this is already present in your JM as well as RACGP. Next question. It's gradually increasing. No, it's gradually increasing and still within the 24 monthly range. So it's not that much of a risk. Even if it's abruptly increasing, if it is still within the range for 24 monthly one, we are not worried about it. If it is abruptly increasing but going into the yearly range or the 6 monthly range, then we change the surveillance to a more less monthly apart one. Am I clear? So if, for example, in the 224 monthly you have been doing, from 3.2, if it has gone to 4.5, then you need to do like 12 monthly. If it is from 4.5 to more than 5, then you do either intervention based on the gender. Yes, very good, Dr. Nadia. No, you're welcome. Next question. A patient, 35 years old female, presented to emergency department after trauma to the eye. 24 hours later, so she had a trauma and she presented 24 hours later. What happened that she was playing tennis game and then she had a trauma to the eye. Now she's complaining of decreased vision and there's floaters and flashes in her vision. What is the most likely diagnosis? Is she having an open angle glaucoma? Is she having vitreous detachment? Is she having floaters, which doesn't make any sense? Is she having a retinal detachment? Excellent. So whenever a patient is coming to you following a trauma, within the first 24 hours with decreased vision and floaters and flashes, this is retinal detachment. With the vitreous detachment, there will be complete loss of the vision abruptly. In retinal detachment, it is a bit later presentation because it takes some time for the retina to detach. And usually patient complains of like, there's a curtain coming down my eyes and I can't see beside a certain point. And he complains of floaters and flashes. Floaters and flashes also happens in the vitreous hemorrhage, but the curtain, falling down of the curtain, is specific for the retinal detachment. So as I discussed last time, you can study the I-1s from the RACGP or the guideline I've shared previously with you guys as well. Okay, look over here. Retinal detachment. This is how it looks like in the fundoscopy. What are the symptoms? All right. Patient describes a shadow or a curtain coming over their vision, and it is associated with the, if the macula is detached, then central visual acuity is completely and permanently lost, and they also associated with floaters and flashes. The most common location is the superior temporal quadrant, this one. And because of the effects of the gravity, that's why patient complains of the curtain drop. Other types of detachment is tractional or exudative, and they can also present with the flashes and floaters. Tractional is caused by mechanical forces on the retina, like our patient had, like a mechanical trauma, as a result of previous hemorrhage, infection, inflammation, trauma, or surgery. Exudative results from increased fluid within the subretinal space. For example, acute hypertension, inflammation, or neoplasm. What else? And you need to refer this patient to the ophthalmology department because it is an acute emergency and they need to fix that before the patient becomes permanently blind. All right. Next question. I hope I'm making things clear for you guys. Is it clear, guys? All right. A young male patient now young male, presented to the GP clinic and complains of hematuria as well as hemoptysis. What is the most likely diagnosis? Goodpasture syndrome, IgA nephropathy, post-streptococcus glomerulus nephritis, or Wegener granulomatosis. So if we all know, if a young patient comes with bleeding while urinating and also blood in the sputum, this is most likely a Goodpasture syndrome. Wegener granulomatosis will have hemoptysis. It doesn't usually come with the hematuria. Mostly it's usually associated with some sort of arthritis. IgA nephropathy and PSGN, they are both glomerulonephritis, in which patient will present with high blood pressure, hematuria, and also sometimes edema as well. And there is mostly an infection of the throat following these two conditions. So if you look over here, this is Goodpasture syndrome. What happens in a Goodpasture syndrome is there is anti-GBM antibodies that are formed, and these antibodies attack the glomerular basement membrane, causing glomerulonephritis, and alveolar basement membrane, causing hemoptysis. So the blood test we do for the diagnosis of the Goodpasture syndrome is the anti-GBM antibodies and urine analysis. Urine analysis will show you there is hematuria and a bit of proteinuria, but predominant hematuria. And the gold standard diagnosis is by the renal biopsy, which show glomerulonephritis, or you can do a alveolar biopsy, which is not recommended. Treatment is that we do removal of the antibodies by doing a plasmapheresis, and you reduce the antibody treatment by giving immunosuppressants like corticosteroids and cyclophosphamide to the patient. And this is Wegener granulomatosis. So lots of things are happening. Mostly patient presents with the lung disease, kidney disease, and the bone disease. So there will be glomerulonephritis, there will be pulmonary inflates leading to pleurisy, there will be arthritis or arthralgias. Other than that, there can be CNS features, there can be eye features, there can be myocarditis, pericarditis, endocarditis, and there will be skin lesions as well. But most of the time, it's heart, lung, kidney, and bones that are affected in the Wegener granulomatosis. Next question. A 40-year-old patient, 40-year-old, presented for follow-up of his results in the GP clinic. He had a history of duodenal ulcer, and H. pylori and biopsy test results is positive. What is the next best treatment for him? PPI, triple therapy, IV PPI, or budesonide? So what sort of triple therapy? Extremely right. Excellent, guys. For what sort of triple therapy we use? What do we use in triple therapy? Can anyone tell me? PPI with 2 antibiotics. Which antibiotics are there? Amoxicillin, metronidazole, or clarithromycin. Very good. Excellent. PCAM, and what I used to do was PPI, amoxiclarithrol, PPI, clarithrol, and metronidazole. So if you remove amoxi, you can give metronidazole instead of amoxicillin with clarithromycin. Triple therapy. Okay, so Helicobacter eradication from RAZGP. Just gonna share quickly with you guys about this one. It's the size. We know most of the time patients who are having reflux or duodenal ulcers, they have H. pylori infection as well. They're more common with the duodenal ulcer. 2 weeks, yes, they are used for 2 weeks. How do we diagnose the ulcers? We do endoscopy, and we take a sample from the ulcer and we do a rapid urease test, and we diagnose the peptic ulcer disease from there. Rapid urease test can be done, and then culture and sensitivity, we take biopsy and we do the histology test as well. Sometimes we can do serology test, but most of the time we do a rapid urease test with the histology and culture. Eradication regimes. Triple base therapy, we use PPI, esomeprazole with amoxicillin and clithromycin. These are for at least 2 weeks. Quadruple therapy can be used as well. Omeprazole with bismuth subsalicylate, metronidazole, or tetracycline. They are first choice in patients who are having clithromycin resistance. So triple therapy and quadruple therapy, all for 2 weeks time. What else? That's it. Okay, let's go back to our questions quickly. Is it clear, guys? So PPI with amoxicillin and clithromycin, triple therapy, PPI, bismuth salt, metronidazole with tetracycline if patient is allergic to the. It will be according to the weight of the babies. In the pediatric age group, we always calculate the doses on the basis of the weight of the babies. All right. It's different. In kids, we always calculate the dose with the weight. Never forget that, guys. 40-year-old male patient coming with the rheumatoid arthritis. He's on methotrexate and hydroxychloroquine. I think we did this question in the last as well. Yes, it's the same treatment for the kids, but PUD is not very common in the kids. Planning to start family, what's your advice to him? So 40-year-old is on methotrexate and hydroxychloroquine because of the rheumatoid arthritis. Now he's want to start a family. What would be your advice? Stop methotrexate, continue hydroxychloroquine. Stop hydroxy and continue methotrexate. Stop both and give leflunomide. Stop both and give adalimumab. Stop methotrexate and start sulfasalazine. Very good. So even if it's a female, we advise the patient to stop methotrexate and continue hydroxychloroquine. Methotrexate in males causes aspermia, reduced fertility, and in female, whenever female is on there, it causes problems with the fertilization, and in babies, it is teratogenic. So we always advise in males and females to, if they are on methotrexate for pregnancy, stop it before planning and then start planning. So option A is correct. Leflunomide is also teratogenic. We never recommend patients to go on that. There's very less evidence that sulfasalazine is also safe during the pregnancy as well. So this can be studied from here. Let me just quickly go through this one. All right. Over here. If you're pregnant or breastfeeding, think you may be pregnant or planning to have a baby, ask your doctor before taking this medication. Do not take methotrexate during pregnancy because it can cause birth defect, harm to the unborn child, and cause miscarriage. It is associated with malformation of skull, face, heart, blood vessels, brain, and limbs. It is very important for the women who are planning to become pregnant to stop taking these. Male fertility. Available evidence does not indicate an increased risk of malformation or miscarriage if the father takes it. However, a risk cannot be completely excluded, and there is no information regarding higher methotrexate days. It can have genotoxic effect. This means that medicine can cause genetic mutations and can affect the production of the sperm, which is associated with the possibility of the birth defects. So in males, it causes sperm mutation. In females, it can interrupt fertilization and also is a teratogenic. That's why we recommend patients not to take them or stop them whenever they are planning for a pregnancy. Is it clear, guys? Simple words. Don't take methotrexate if you're female or a male planning for a baby. Thank you. All right. Next question. A mother brought her child which complains of exercise-induced asthma. Recently, football player, 10 years of age. What is the best advice for him? Salbutamol, montelukast, LABA, or inhaled corticosteroids? So whenever they're coming to you with the exercise-induced asthma, what is the best advice? Give salbutamol before the exercise, give montelukast before the exercise, give LABA or inhaled corticosteroids. Very good, excellent, guys. For children, we usually don't start on inhaled corticosteroids right away unless the patient is having persistent severe asthma, right? And having recurrent episodes of the acute attack. But if it's just the exercise-induced wheeze or exercise-induced asthma, the recommendation is that 15 minutes before any activity, give them a puff of the salbutamol through the metered device. And then they can play. They will not have any breathing troubles when they're playing. So the recommendation is this. I'm gonna go with this one for you guys. Okay. All right. Exercise and sport. Do you or your child ever get asthma symptoms during or after sport? So it should not be stopping you. What are the things? Warm up before exercise, keep as fit as possible, avoid exercise in high level, try breathing through your nose. Where is the other instruction? Oh, sorry, I thought this is having instruction. Sorry, wrong guideline. This is the one. Sorry about that. I'll remove this one. Management of the childhood asthma. So inhaled corticosteroid is recommended for persistent, moderate to severe, not for the normal mild one. It's not here as well. Patients are taking only SABA are mostly well controlled, or although there may be patients who can benefit from the ICS, but mostly, guys, with patients who are having exercise-induced asthma, we use SABAs. I don't know where I have put the guideline, but this is not the right one. Let me just search it out for you guys quickly. Sorry about that. Oh, here it is. This was the one. How can my child manage their asthma while playing sport? Tell your child to take the reliever puffer, which is salbutamol, 15 minutes before warming up if there's just a part of their asthma action plan with the GP. Make sure they warm up before exercise, watch for asthma symptoms, and give your child their puffer, reliever puffer, which is salbutamol if the symptoms appear. They should return to exercise only when the symptoms have subsided. If the symptoms reappear, then give them a reliever again and don't let them exercise. Remember that asthma symptoms can occur up to 30 minutes after your child has stopped exercising. Have the reliever medication readily available. Is it clear, guys? Sorry about the mix-up. I thought I had put that one over there. All righty. Clear? Regarding the exercise-induced asthma in children. It's the same rule that we follow in the adults as well. The recommendation is almost the same. Reliever medication is salbutamol, SABA. A mother came with 2-year-old child to get genetic testing for cystic fibrosis as the child was having growth restriction with repeated chest infections in the GP clinic. What will you do next? Do the test, refer the test for the specialist, ask to come when the child becomes older than 18 or 16 years of age, reassure or order a sweat chloride test. I have very excellent students today. All right, whenever a patient is suspected of having cystic fibrosis, we don't jump to a genetic test first because it's very expensive. Number two, it's not covered by the Medicare. You need to have a specialist referral and a certain age for you to qualify over that. And a GP cannot order a genetic testing for cystic fibrosis. It has to be ordered by a specialist, for example, our respiratory pediatrician. So what a GP can do is next to the best thing, which is order a sweat chloride test, which is basically, if it is positive, you don't need to do a genetic test unless the patient's mother is very consistent. If sweat chloride test is positive, we suspect, along with the clinical correlation, that patient might be having cystic fibrosis, and we start the treatment of that right away. Testing for the cystic fibrosis is a multi-step process. A complete diagnostic evaluation should include. So in Australia, when a baby is born, they do a newborn screening test within the first 72 hours. No worries. Thank you so much, Dr. Charles. That's a very nice compliment. But whatever I do is I try to help you guys as much as possible so that you guys can achieve your dreams of working in an Australian health system. I was also a student of Dr. Arshan, so I'm very much close to first aid AMC. I have taken both of the courses and I have passed my exam in first course. And immediately after that, I got a job because my concepts were very good because of the course and the wonderful tutors in it. So cystic fibrosis, multi-step process. First of the thing is that within the first 72 hours, when a baby is born in Australia, we do a heel prick test. In a heel prick test, there is more than 103 genetic diseases which are ruled out. Cystic fibrosis is one of them. If a baby has, and it depends on parents to do a heel prick test or not. If a baby falls from the cracks of the heel prick test and is coming with the repeated chest infections, stunted growth, ileus, then we do a sweat chloride test. If it is positive, then we suspect that the patient is having cystic fibrosis. Then we refer to the patient to the specialist and they can order a genetic or carrier test, and a clinical evaluation can be done at the cystic fibrosis center. There is a whole community where they do all of this for the patients. So this is the main thing. If your baby shows symptoms of cystic fibrosis, or if the baby had a positive newborn screening test for the cystic fibrosis, we do a cystic fibrosis sweat test, in which we test concentrations of the chloride and sodium inside the baby's sweat to diagnose. Because in cystic fibrosis, there is a defect in the chromosome 13, which basically is telling you about the transport of the chloride and the sodium. It's a defect in that. All righty. Next question. Is it clear, guys, about the cystic fibrosis? We never jump on to the genetic testing as a first step. We start with the heel prick at the newborn stage, go with the sweat chloride, and then if required, the specialist can organize a genetic testing or a carrier testing in the parents. If you don't want the baby to have it, you just test the parents. Next question. Old man presented to a GP clinic with voiding difficulties. What are the voiding difficulties? He is having incontinence. Hey, you did a digital rectal examination and the prostate, you found it to be of normal size and shape. What is the next step in management of the incontinence of this patient? You do a back pain with X-ray, which does not make any sense. Give analgesia to the patient. I don't know what day-to-day activities mean, or we do behavioral modifications of the patient. Now, this is a very incomplete question, guys. They have not told you about what kind of incontinence the patient is having. Either it's a stress incontinence or a overflow incontinence, right? So most of the time in males, what sort of incontinence we have? What? Very good. Overflow incontinence, right? So in overflow incontinence, whenever they go to the restroom, they have the urge, they go to the restroom and they lose the control over their bladder once they go through it. So when we have a patient of that, we do a behavioral modification as well as lifestyle modifications in them. So we eliminate things from their diet. Excuse me, guys, just give me one more. All right. So whenever a patient is having either stress incontinence or the overflow incontinence, we start with a lifestyle modification and then exercises. Kegel exercises are important, very important in females, but behavioral or bladder modifications we can do in males as well. So if you look at this flow chart, it will help you. If a male is presenting with a urinary incontinence, we do an initial assessment with history physical examination. We have a voiding diary. We do a urine analysis. And we also do a post-void residual ultrasonography and a renal tract. Because in males, if they are having bladder problems, this most of the time related to some prostate issue or some genitourinary tract anatomical problems. So we do this. If it's a urge incontinence or an overflow incontinence, oh, sorry about that. The first thing we do is the behavioral modifications. I know it's written in the mixed urinary incontinence, but we do it in the urge incontinence. Behavioral modification is not done in the stress. In the stress, we do the Kegel exercises first. Behavioral modification is very important in the urge incontinence. Number 2, bladder retraining is also very important in the urge because there is an overactive bladder syndrome. So we do bladder retraining in the urge incontinence. Pelvic floor muscle exercises, not very much helpful in the urge incontinence, but very much helpful in the stress incontinence. Trial of anticholinergic, very much important in the urge incontinence. So this is how we do stuff, how we investigate and then treat the incontinences. Is it clear, guys? So stress incontinence, not very much common in males unless they had some procedure that caused their perianal muscles to collapse and not support the bladder. Urge incontinence is common in them because of some drugs, prostate itself, and overuse of the caffeinated products. So you can do the bladder retraining, you can do the behavioral modifications in the urge incontinence. All right. Next question. A female is coming in the first trimester. She's trying to stop smoking. How will you help her? Give her nicotine patch, give her bupropion, or give her venlafaxine? Very good. Is venlafaxine, are we able to take it during the pregnancy? Is venlafaxine safe in pregnancy? Can anyone tell me? No, why? Can anyone tell me why? I'm just going to show you guys what it does. Sorry, just give me a minute. So, can venlafaxine be used in the pregnancy? What it does is, it doesn't cause fetal abnormalities, but it has been associated with increased risk of spontaneous abortions. So it's not safe in the pregnancy. The safest SSRIs that you can take, yes, very good, Dr. Zenith, is fluoxetine. So the best thing you can do is give her a nicotine replacement patch. It's very, very effective. It works for 24 hours. You can remove it. It comes in the box. It is on PBS as well. So she will not have to pay a lot of money through her pocket. She can go through a smoking cessation program as well, where they support the women who are pregnant undergoing smoking cessation, because in pregnancy, we ask them to cut down smoking to zero, not step down to like 1 cigarette a day, zero, because smoking itself is a teratogenic to the babies. So they had to go through the withdrawal effects, which we can control by giving them the nicotine replacement patches, which is basically written in what we have discussed in this guideline in the RSCGP. All right. I'll show you guys. Just give me a minute. All righty. Are you guys able? Oh, just going to change the screen. Management of smoking in pregnant females. It's the most preventable cause of the adverse outcomes in pregnancy. However, most smokers who become pregnant continue to smoke, and most of those who quit relapse after the delivery because it's an addiction. It takes time to cut down on it. It takes a lot of support to cut down on it. So what can we do? We can do behavioral counseling in the patients, like encouragement. We can do nicotine replacement therapy. Although its efficacy is uncertain, adequate doses of the nicotine and good adherence may be required for the best result. The use of NRT in pregnancy is less likely to be harmful as compared to smoking. Pregnancy is a window opportunity for the smokers to quit down smoking altogether. So women are in the behavioral counseling. What we do is encourage them that if they do smoking, they are not protecting their baby. So quitting smoking is going to protect the baby's health and reduce the risk of complications in the mother itself and also the baby. Continuing postpartum relapses. The most people who are at risk of it is the Aboriginal and Torres Strait Islander. It's a rough estimation, but it's same in the Caucasian population as well. So what effects of smoking have on pregnancy and before the pregnancy as well. So fertility is that it can cause delayed conception. It can cause infertility in both of them. Obstetric is that it can cause spontaneous miscarriage. It can cause preterm birth, placenta previa, placenta abruption, stillbirth, ectopic pregnancy, premature rupture of membranes associated with the preterm birth as well. Preeclampsia, very, very common. What it can cause in the baby is the growth restriction, low birth weight associated with the growth restriction, small for gestational age associated with both of above, and birth defects like limb, oral eye defects, GI defects, and other smaller defects in the heart as well. The child will be at risk of the sudden infant death syndrome, type 2 diabetes, obesity, hypertension, high cholesterol levels, nicotine dependency, respiratory illnesses, cognition, behavior, and psychiatric disorders. All right. Any question, guys? All right. Next question. A man was working in the garden. He fell and rubbed his face on grass. Afterwards, he had a very blurry vision, but there was no pain and you couldn't find any redness of the conjunctiva. What's the next investigation you want to do in this patient? Fluorescein dye, fundoscopy, MCL, or refer to the ophthalmology department? All right. Majority are going DNA. All right. What we usually do in the emergency department, if a patient is coming with a foreign body in the eye, is we do a full eye examination. We do a full eye examination with visual acuity, with the slit lamp, with the fluorescein dye. If we find a corneal abrasion or a foreign body, we refer the patient to the ophthalmologist urgently. We talk to the ophthalmologist on phone. We let them know what has happened. If we have a person like a consultant, emergency consultant, who can take out the corneal foreign body, then we do that and refer the patient to the ophthalmology department outpatient for follow-up. If we can't, we just make sure that we give drops in the eye that prevent infection and drops in the eye that prevent pain, and then refer the patient to the emergency of the hospital who has an active ophthalmology department. That's what we do. Okay. So this one. Yep. Okay, let's look at this one. This is the Royal Victorian guideline. Chemical injuries, foreign body, doesn't matter. Whatever sort of injury to the eye is. We wash the eye. Prior irrigation, we ask about the injury. We do the primary survey and check the pH of the eyes if it is a chemical injury. If it is a corneal abrasion or a foreign body, no need to check the pH of the eye. But in the foreign body as well, we do irrigation of the eye as well. And then we do the full anterior segment evaluation. We give local anesthesia before the examination. We check the outer lid, evert and sweep under eyelid to remove any particular matter. We examine the cornea for haze or epithelial defect with fluorescein dye. We examine the conjunctiva with the fluorescein dye. We examine the limbal ischemia with the fluorescein dye. And if there is corneal abrasion or a chemical injury, we refer the patient to the ophthalmology department. But before doing that, we make sure we have given an antibiotic drop and a painkiller drop. MCL is a sort of a painkiller drop to the eye. But before we do that, we give a painkiller drop to the eye before we send the patient to the ophthalmology department. Every case with an epithelial defect, which is a corneal abrasion or a reduced vision, should be reviewed by an ophthalmology registrar. So it's very important that you make sure that these patients are seen by a specialist. It's not MCL, it's MCLR grid. It's basically a visual acuity test. This is not MCL, this is MCLR grid. MCLR grid. All right. Any question, guys, from the corneal abrasion / chemical injury guideline or management? Nope. Okay. A 28-year-old female, she has a positive HPV, which is non-16 and 18, and negative for 16 and 18. What is the next step in management of the patient? Repeat the test. When? We don't know. Do the cervical screening test in 6 to 12 months. Do the cervical screening test in 3 to 6 months. Do a colonoscopy in a patient who have a cervical screening test positive with the HPV. Do we do a colonoscopy in the patient with a positive cervical screening test? What do we do? What sort of test we do if it is persistently positive for very bad bugs? Is it a colonoscopy or a colposcopy? Very good, it's a colposcopy. So whenever a female is coming to you and we have done our cervical screening test and she is coming positive for a non-16 and 18 with the genetic testing or HPV testing, we do a liquid-based cytology. If it is negative or positive, doesn't matter. If it is a non-16 and 18, we repeat the test in 12 months. If it is positive, we repeat again in 12 months. If it is twice positive in 12 months' time, then we refer the patient to the colposcopy. So if you look over here, this is very tiny. I'm just going to increase the size. We are talking about this one. If you have done a HPV testing and you have detected a non-16 and 18, you did a liquid-based cytology, it's negative or positive for low SIL, doesn't matter. Either way, you repeat it again in 12 months. If you have again detected HPV genotyping non-16 and 18, you do again liquid-based cytology, doesn't matter. Negative or low SIL, you repeat it again. So twice you have repeated. If then it is positive, doesn't matter what kind of HPV, then you refer for the colposcopic. If it is twice negative, then you do the routine 5-yearly screening. It's clear, guys? So non-16-18, do liquid-based cytology, positive or negative, doesn't matter, repeat again in 12 months. Positive, negative, doesn't matter, repeat again in 12 months. If negative, 5-yearly screening. If positive, any type, then you do a colposcopy. If it is 16 or 18 detected, doesn't matter the result of the liquid-based cytology, we refer the patient for colposcopic assessment. If HPV 16 and 18 non with the high SIL, then doesn't matter. You send the doesn't matter what sort of HPV it is. If it's a high SIL, then you refer the patient for colposcopic assessment. All right. Any question, guys? Cervical screening test is very, very important for your exam. I cannot emphasize this enough. Okay. So they have given you an X-ray which shows slipped capital femoral epiphysis of a 14-year-old boy with a BMI of 13. Best treatment they're asking: bed rest, analgesia, pinning of the joint, or crutches. I'll show you guys the X-ray. So this is the X-ray. This is the right side and this is the left side. Which one is the slipped capital femoral epiphysis, the right side or the left side? Very good. So this line, the Stenton's line, it should be passing through the head of the femur from the neck. But if it is aligning with the top of the head, then it's the slipped capital femoral epiphysis. Very good. So we do, the initial treatment is that we do offloading from the joint. So we ask the patient to do complete bed rest or use of crutches, and we give analgesia, and we refer the patient to the emergency or the orthopedic department for having the pinning of the joint done. right, look at this. Orthobullets, slipped capital femoral epiphysis of the joint. Yes, we need an urgent referral because as long as delay and if the patient is not following offloading from the joint, it can cause permanent damage to the hip. So this is what it looks like, slipped capital femoral epiphysis, very common in the children who are obese, tall boys, pubertal ones. Treatment is usually percutaneous pin fixation or contralateral pinning if indicated for patients at high risk. Very common, obese children, male, African Americans, 16 to 10 years of age. Left hip is more common, cannot be said. It can occur in both. What are the risk factors? Obesity, acetabular retroversion, femoral retroversion. No need to know about the pathophysiologies. Associated conditions are important. So if they're obese and very tall, there may be something going on with them, either thinning of the bone with the hypothyroidism, renal osteodystrophy, growth hormone deficiency, or panhypopituitarism. Very important for you guys to know about this. Or can also occur in the Down syndrome. Classification is that stable, able to bait wear with or without the crutches. Unstable, very, very important for you guys to urgently refer them. Acute, chronic, acute on chronic, mild, severe, moderate, grade 1 to 3. Presents with hip pain, groin pain, thigh pain, knee pain. Usually what we do is physical examination in which they will have an abnormal antalgic gait, abnormal leg alignment, and externally rotated foot. Just give me a minute, guys. All right. So they will have an abnormal gait and leg alignment will be abnormal. External rotation of the foot, sometimes like that in the femur fracture. And neurovascular sometimes will be there if a patient is coming with a chronic slipped capital femoral epiphysis. Radiograph is the same as I have shown you. Klein lines or Staten lines, S sign, is that a line is drawn from the neck of the femur towards the joint, and if it is passing through the head, that's good. If it is passing above the head, it means there is some slipping. MRI, best imaging to do that, but X-rays can also be done. So treatment is that percutaneous in situ fixation, and very important for you guys to tell the patient that they need to offload the joint and use pain relief, and an urgent referral for the fixation of the hip, okay? All right, any question, guys? All right. Next question. A female with a family history of GD, gestational diabetes, GDM, comes for her OGTT at 8 weeks, which was normal. What to do next? Do nothing. Do OGTT again at 28 weeks. Do HbA1c at 28 weeks, or reassured that there is no risk. So patient who has a family history of gestational diabetes, do we usually do the OGTT at 28 weeks, or do we do OGTT as soon as possible? Answer is absolutely correct. Very good, Dr. Charles, very good, Dr. DW and Zenith. Whenever there's a patient who has obesity with a BMI of more than 30, if they have a first degree relative who has gestational diabetes or diabetes, if they had previous history of gestational diabetes, if they have pre-diabetes, we usually do it as soon as possible. And if not, then we usually do it at 24 to 28 weeks, roughly this time period. But a risk factor female, we do it as soon as possible and can repeat it again, because these patients are at risk. We don't want them to fall through cracks. So when do you repeat the OGTT in pregnancy? If female has GDM in previous pregnancy, we do OGTT as soon as possible. If negative, we repeat at 24 to 28 weeks. Other women with any other risk factors are usually screened at 24 to 28 weeks by 2-hour OGTT with 75 gram of glucose overload. All right. I don't think so we need to go into that much detail, but every patient who has diabetes is done OGTT as soon as possible, and then at 24 to 28 weeks, and postpartum at 6 weeks, and then they are screened every 5 to 3 yearly as well. Any question, guys? 7 days post-op patient is presenting and complaining of dyspnea and breathlessness. Most appropriate investigation: CTPA, echocardiography, ECG, chest X-ray. Very good. So what happens is that in hospital, the chance of patient getting a pulmonary embolism or a DVT is very high, because when they're sick, they are less mobilizing, they are having comorbidities, and they are not having as much adequate hydration as possible. So whenever a patient who we think will have some stay in the hospital, we start them on VTE prophylaxis, either chemical or non-conservative like TEDs and SCUDs, or we start them on chemical prophylaxis with the enoxaparin or heparin, whatever. Yes, if there is a family history of diabetes, even not GDM, we do screen them earlier. I'll show you guys about the SA Health. If you look over here, this is the SA Health. So if you look over here, it comes with guidelines like this. So whatever you need to study about, it can be there. So risk factors for the patient to be screened: previous GDM, previous elevated blood sugar levels in the pregnancy or non-pregnancy, pre-pregnancy BMI is more than 30, age is more than 40, family history of first degree relative with the diabetes or sister with the gestational diabetes, previous baby was like huge, PCOS, medications like corticosteroids, antipsychotics, or ethnicity like Indians, Asians, Aboriginals, Maori, Middle Eastern, and non-white Africans. These are the high-risk groups, and we screen them. All right. Okay. So we do a CTPA in these patients. Before they have asked you the most appropriate. If they ask you the next investigation, what would you choose? Non-pregnant women, we do. If they are in the reproductive age, then we would prefer a VQ scan. If VQ scan is not available, we can do a CTPA. Very good. We'll do an X-ray for them. If the patient is having dyspnea, breathlessness with chest pain, what would be the next investigation then? ECG. Wherever there is chest pain, forget about everything else. Do ECG first, please. ECG, troponin, chest X-ray. These should not be missed in a patient who is complaining of chest pain. And then you can decide on either what further test you want to do. So, well score, likely B, do CTP or VQ scan. All right, next question. Baby 17 days old with jaundice. Normal weight gain, stools, urine normal. What can be the cause? Biliary atresia, breast milk jaundice, or avian compatibility? So 17-day jaundice can happen with the breast milk jaundice or can be a normal physiological jaundice as well. So even in option D or E, if they give you physiological jaundice, don't go for breast milk jaundice. It is physiological jaundice. Biliary atresia occurs when the patient have jaundice, and in jaundice, 15% is the conjugated hyperbilirubinemia. Then this is biliary atresia. And it usually happens after the first week of the baby being born. It's a huge topic, which will be covered by Dr. Arshan when you guys are studying pediatrics, but you can also study, if you want to, from RCH. Pediatric guidelines is the Royal College of Pediatricians. So you can study from here. Why is this not opening? Okay, let's see if we RCH. So with the kids, you can follow the RCH guidelines. Royal Children's Hospital. It is not opening for some reason. Oh, here you go. So this is Royal Children's Hospital Melbourne guidelines for everything in the kids. You just write what you need to know about clinical practice guidelines. Open this. And sorry, my computer is taking a lot of time. Oh, thank you. I'll do that. Okay. So A to Z, whatever you need to know about, you can find it here. Okay. So you can just type whatever you need, go to the clinical guidelines, and it will come up. So jaundice in early infancy. Every jaundice which is less than 24 hours is pathological, more than 2 weeks is prolonged, and within this period is physiological. There are many causes of it. You guys can read it. I'm not going to go into detail. But if a jaundice is presenting after the first day of life, baby is eating fine, is pooing fine, urinating fine, there is weight gain, don't be worried about it. But from the onset of the jaundice, like it's come up on third day, but it's been more than 2 weeks, the jaundice is not settled, then this is a prolonged jaundice and needs to be investigated. Alrighty. Last couple of questions. Patient is 3-day post-op for hip transplant. There is no stool passage. What can be the cause? Adhesion, pseudoocclusion, or carcinoma? Very good. So most of the time with the GA, and because of the blood loss and electrolyte loss and poor oral intake, patients post-operatively can develop pseudo obstruction. So the best thing to do is hydrate them and give them some Movicol to get the things moving. If it is worsening pseudoocclusion, you can decompress the whole gut by putting an NG tube. Ogilvie syndrome, very good, is Ogilvie syndrome, Gillive. All right. Pregnant patient was diagnosed with group B Streptococcus infection at 12 weeks of pregnancy. Now what do you need to do? Give penicillin during labor, give antibiotics to newborn, give antibiotics after labor, or do nothing and let the infection brew. Very good. When do we do the GBS screening in a patient? 34, 36 weeks. This time period is also good. So if a patient who is having previous infection, doesn't matter if we do the screening or not, if they had the infection in the previous pregnancy, we give them prophylactic antibiotic during the labor. But if the patient is diagnosed with GBS, we treat it during the pregnancy and then give prophylactic antibiotic during the labor as well. So if you open this one, it'll tell you much needed information about GBS. It's the leading cause of newborn infection. That's why there is a screening program for it. Oh. Primary risk factor is maternal colonization of the infection. 50% will transmit. That's why we do the screening, and it's associated with neonatal sepsis, low birth weight, prolonged rupture of membranes. All more women who have vaginal retinal cultures positive at 36 weeks should have appropriate intrapartum antibiotic prophylaxis unless patient is having a C-section. If you are having a C-section, no need to give antibiotics because baby is not going to go through the vagina. If it's a vaginal birth, you need to give antibiotics. Although a shorter duration of intrapartum antibiotic is less effective, 4 or more hours of prophylaxis is done. So you do it at least before labor. What else? That's about it. Alrighty. Let's see if we have any questions from any. That's it for today. I hope you had a good recall session with me, guys, and you enjoyed it. And I have given you a bit of peek into what our course is usually like in every class of recalls we take. I hope it was helpful for you in making a decision about whether you want to join the course or not. I would definitely recommend you guys. It's worth spending some money in order to pass the exam. But whatever you guys if you guys have any questions regarding the course, regarding the recall section, then I'm happy to answer them. You can contact Dr. Arshan about the course if you want to enroll in it. And I'll see you guys in future if you are going to be my students. And if not, all the best for your exams. I hope you guys achieve your dream. Just be very dedicated and follow the guidelines and you'll be okay to pass the exam. Thank you so much. I hope you have a great night. Thank you.